I don't know that we are set apart from other research fields. We have the same rigor in our research. The thing is, we are clinicians, and the sources of our research questions generally come from our clinical practice. I always call it clinical wonderment. What is the clinical question that nags you when you go home? You scratch your head and you say, why does that happen? Oh my gosh, it happened again. Why aren't we doing something about it? And that's usually the source of our research. Not unlike other clinical researchers in medicine or dentistry or other things. Quite often that's the clinical wonderment's what drives your program of research. So, and then the only other thing I could say that might be different about our approach to research is our discipline is a holistic discipline in terms of how we view the world. So if you look at philosophy of science perspectives, we don't fall into a positivist stance. We're not necessarily quantitative in all our research. We don't necessarily say the clinical trial is the bee's knees. We view whatever this clinical wonderment is from a whole array of points of view, including, because we deal with people, including the people who are experiencing the phenomenon of interest. We don't cut them out of the research process. It wasn't until much later that I learned you can officially incorporate persons who are experiencing the phenomenon as your co-researchers. I didn't learn how to do that until later. And it probably wasn't part of what I was being taught early on either, because there wasn't a lot of it going on in the places that I was. But that's really what I believe you have to do, just as I believe that for my clinical practice. I'm not the end-all, be-all, know-all for people that I'm working with to provide care. I always say I'm a public health nurse. I work with people. We grassroots. We work with their strengths. It was only much later I learned what I was doing is called health co-production. So a lot of these things I did, believed in, valued, drove my work, didn't have an official name for it because I didn't know it existed, found out about it later. I said, oh, that's what I've been doing, health co-production. But it's the same notion in research. We co-produce knowledge because the phenomena aren't existing just in my eyes, for my needs, to put a line in my portfolio, $1 on my NIH. No, this is about real people and real needs and how to approach it in a way that's going to build knowledge appropriately with them, so it's usable. It has to be applied. So that's another earmark of our work. For the most part, it's applied. It informs intervention. Yes, we do basic research, but it builds to eventually being able to inform intervention. What makes anyone think that being practical doesn't mean you have to have knowledge to support it? Of course you do. Where does that practical stuff come from? The end of my thumb? No. It's got to come from evidence. Again, evidence-based stuff, that language came later, but we always knew you had to have evidence to support your practice, and you had to get that evidence in an appropriate, rigorous way. You had to follow the rules. You had to build it in an appropriate way.